Hello everyone and welcome back to Clinical Cousins YouTube channel, where today we're going to go over how to change our heart rate, its conduction, and its contractility, how hard it squeezes. So our heart rate is generally calculated in the amount of beats per minute. This means how many squeezes and relaxes does our heart have every single minute. Well, for an adult, this can be anywhere between 60 and 100 beats per minute, with an average of around 72 beats per minute. Now, our heart rate is largely controlled by autonomic effects. Remember, the autonomic nervous system is basically the sympathetic and parasympathetic nervous systems that are having our fight or flight response or our rest and digest response. So, although if you were to cut out all of the nerves to the heart, it would still beat because the SA node has automaticity or spontaneous depolarization. But why is it beneficial to us to use our autonomic sympathetic and parasympathetic nerves to control our heart rate? Well, it's very beneficial because it allows us to control the amount of output, the amount of blood pumped from the heart based on the demand that we are putting on our bodies. So if we are exercising, for example, we are going to need to increase our output, our blood flow. This is the system that allows us to do that. Also, it's implicated in every single disease process. So our heart rate is called chronotropy, chrono like time. So drugs that increase the heart rate are called positive chronotropes, while drugs that decrease the heart rate are called negative chronotropes. So our sympathetic nervous system will increase our heart rate. But how? Well, epinephrine and norepinephrine from the adrenal medulla and norepinephrine from those long post-G sympathetic nerves actually activate our beta-1 receptors. So these beta-1 receptors are coupled to aldenylyl cyclase and will actually increase cyclic adenosine monophosphate, which will eventually place more funny sodium channels in our SA node. Well, that was a lot, but really what we need to remember is that the sympathetic nervous system will increase our heart rate. So do you remember our CISR acronym, CISR? Beta 1 speeds up. It speeds up our heart rate. Well, how do we lower our heart rate? Well, our parasympathetic nerves, well, specifically our vagal nerve known as cranial nerve 10, it's very, very important. This vagal nerve will release acetylcholine onto a potassium acetylcholine receptor on our SA node. So this receptor binds to acetylcholine that's released, and what it does is it opens up potassium channels. Now, this will make potassium flow out of the SA node, which makes it more negative. You can think of it, makes it more sleepy, more lazy, really, really slow. So an example of a drug that will speed up our heart rate is maybe epinephrine, because it activates those beta-1 receptors. And on the contrary, we have a drug that will slow down our heart rate, which is propranolol, metoprolol, atenolol. These are all these cardioselective beta blockers, except for propranolol. And why do they work? Because they are blocking our beta-1 receptors. They are blocking that sympathetic excitatory response. Now, what about our heart's conduction velocity, or Dromotropy? So dromotropy is important because it refers to the speed of conduction, the velocity of conduction of electrical impulses throughout the heart. Now, the most important area of the heart when we're talking about conduction is the AV node. Now, any sympathomimetic, which is just a fancy way of saying any drug that mimics the sympathetic agonist or the sympathetic nervous system, will increase conduction through the AV node, meaning that an impulse traveling from here to here is going to go through the AV node a lot faster. Now, these drugs will activate adrenergic receptors to increase the amount of calcium and will increase the conduction speed through the AV node. Now, on the other hand, we have our parasympathetic vagus nerve. Remember, this is our favorite parasympathetic nerve. It's cranial nerve 10, and you guessed it, it's going to activate that potassium acetylcholine channel, which will allow potassium out of the cell. Remember, positive potassium is going out of the cell, so it makes us more negative. We're getting more sleepy, more slow. So this means that AV node is going to be less willing to fire. Now, you might be saying, well, why would we ever want to do this? This sounds like a bad idea. Well, if your patient has a supraventricular tachycardia, meaning your patient is having a heart rate that is so fast that it is dangerous, and it is because there's too many impulses in the top that are traveling to the bottom. This is supraventricular tachycardia. So your patient is going to be having so many electrical impulses from top to bottom, and the AV node is allowing all of this to happen. So how does this impact our ventricles? Well, our ventricles are going to beat really fast, and you might think, oh, well, that's a good thing. We're going to have more blood flow. Well, actually, the ventricles are going to be beating so fast that they're not squeezing very well. So how is stable supraventricular tachycardia treated? Well, you're going to want to do some vagal maneuvers like the Valsalva, you do carotid massage that will naturally decrease AV conduction. But if that fails, you're going to use a drug called adenosine. Now you grab 6 milligrams of adenosine and then you slam it into the vein through an IV, and then you rapidly push 20 milliliters of saline flush right after. Now you're then going to see your patient's monitor flatline as all of the conduction is stopped. Well, why did we just stop the patient's heart? Well, if all goes well, remember the SA node has automaticity. The SA node should have the fastest phase 4 depolarization, and this should pick up and return to normal sinus rhythm. Now, if that doesn't work, you're going to use 12 milligrams of adenosine and then try the same thing. Now, okay, let's talk about contractility, called Inotropy. Now, this is how hard our heart is squeezing, how strong is it? Well, we know that we can increase the amount of contractility by increasing intracellular calcium. Remember, calcium is necessary for the heart to squeeze, to contract. Well, how do we do this? Our sympathetic nervous system uses beta-1 receptors. Remember, they're very important in the heart. It uses those beta-1 receptors to increase the amount of calcium channels in our ventricles and also to phosphorylate. By the way, phosphorylate just means to activate a protein called phospholamban. Now, this allows our calcium ATPase on our endoplasmic reticulum to gather up calcium more quickly so that it can be ready for another contraction. Now, on the other hand, we have the parasympathetic nerves, which really only work on the atria. This is an important point. So acetylcholine is going to be released, and it will actually inhibit adenylyl cyclase. Remember, adenylyl cyclase is involved with beta-1. So the parasympathetic is going to stop that. So what is it doing overall? Well, it's going to decrease calcium influx into the cell, in the atria, not the ventricles. So this is the golden rule. If you use drugs that mimic the parasympathetic nervous system, you cannot directly affect the ventricular contractility. You can only affect the atrial contractility. However, if you use drugs that block the sympathetic nervous system, like beta-1 blockers, like metoprolol, or calcium channel blockers like diltiazem or verapamil, then you can affect the contractility. Why? Because you're actually inhibiting the sympathetic nervous system. Now, this is one of those reasons why we don't give calcium channel blockers to people in congestive heart failure. Well, what if there was a drug that could decrease the heart rate to allow more filling and conduction so that we could have the heart fill with more volume, more end diastolic volume, more preload, but what if it also increased the contractility of the heart at the same time? Well, this would be the golden drug. Well, we do have a drug like that. It's called Digoxin, but the downside is it's extremely dangerous. And if you have a level over 2 nanograms, then you can have toxic levels in your blood. So briefly, what this drug does is it binds to and inhibits sodium potassium ATPases. Remember, this is found all over our body. We're focusing on the heart. Well, this allows sodium to accumulate in the cell. This means that the sodium calcium exchanger will have no motivation to kick out that calcium, and calcium will accumulate in the cell. What the overall thing I want you to remember about this drug is it's going to slow your heart rate and conduction while increasing contractility. So you're going to have more blood filling and a stronger squeeze. So this is why it's great to use in patients with heart failure, with patients who cannot squeeze enough blood. Well, what else will increase our contractility? Well, Frank Starling says that when you stretch a ventricle with blood, you increase that end diastolic volume, you increase that preload, it's going to make the troponin more sensitive to calcium, and your muscle is going to contract harder. So you can forget all that. What I want you to remember is that simply, if you stretch a rubber band, the harder you stretch it to a point, it's going to snap back really quickly and with more force. So when we increase the filling time, basically when we increase the end diastolic volume or preload, we will also increase the contractility at the same time. So we're going to have a strong contraction. So as always, thank you so much for taking the time to learn with us today. And I hope that these topics are just a little bit more clear. And again, thank you. And I hope that you like and subscribe for more content.